Good to see so many of you here today. I'm Nimisha from the 33N and Clear Communications team, and I'll be hosting today's webinar, where we'll discuss our Clear UEC Frimley project. This session is part of our Clear Impact webinar series, which brings together those involved in delivering our latest transformation projects to share their learning and impact of their work. And this includes frontline staff who led the projects on the ground, as well as those who supported them from the National Clear team. A reminder that today's webinar is being recorded, so we can share the link afterwards on our website and across our networks. So today's webinar centres on our Clear UEC Frimley project, which focused on optimising pathways for older people living with frailty attending UEC services at Frimley Health NHS Foundation Trust, with the aim of improving outcomes, reducing demand on services and avoiding unnecessary hospital admissions and lengths of stay. Today, we'll be joined by Louise Duvall, Advanced Frailty Practitioner at Frimley Health NHS Foundation Trust, Kate Hyett, former Lead Frailty Pharmacist at Frimley Health NHS Foundation Trust, Lucy Purdy, Workforce Lead at NHS Frimley ICB, and our very own Lisa Newbull, Senior Clinical Consultant with the National Clear Programme. We'll just take a quick look at the agenda. So Lisa will give an overview of the National Clear Programme and will then hand over to Louise and Kate, who will take us through their project, including key findings, recommendations and projected impacts. Lisa will then lead a personal reflection segment in conversation with Louise and Kate, where they'll talk about their experiences of driving this transformation project. We will then finish with a Q&A, which will be your opportunity to ask questions, either through the Teams chat or with the hand up emoji. That's all from me for the moment, so I'll now hand over to Lisa, who will kick off proceedings for us.
Thanks, Nimisha. So hi everyone, I'm just going to give you a brief overview of the Clear programme and what we do here at 33N, for those of you that are not familiar with our work. So we are the National Clear programme. It was originally developed in partnership with Health Education England, and the view of it was to educate staff and sort of build that transformation capability into frontline services with clinicians at the heart of transformation of their own services. So we're now sponsored by NHS England, and we're also commissioned by local ICBs to do Clear programmes within systems. And it really is about sort of empowering those frontline staff to innovate in their own services. Next slide, please. So just to give you a quick overview of how a project would run. So it's quite a unique methodology, and it runs in 4 separate phases. First one being clinical engagement. That's where we really get down into the services and speak to a range of staff across the services to find out what their challenges are, what works well, what doesn't work so well. And with a real sort of focus to get that lived experience from the staff working on the ground. The next phase then is our data interrogation. And whilst we're doing our clinical engagement, in the background, our data team are extracting usually around 5 years worth of data, so that when we get to our data interrogation phase, we've got these lovely dashboards that we can analyse, so that we can pick out any of the themes that have come out from clinical engagement and sort of either back those up or refute them and see if that's what the data actually says. So from those 2 phases, then we sort of triangulate all of that data and come up with our more in-depth themes as to what's really going on in the service. And that's when the fun starts. We sort of start to think about our innovative solutions and you know, great new ways of how we can work to make things better. And at this stage, we try and re-engage with the clinicians, because it's really important that those innovations and solutions come from within the service, because they know what will work for them. We then refine that and do any workforce modelling that we might need to do, if there's any changes to the workforce or the pathways and how the service works. And then we sort of neatly put all of that into a series of recommendations for our final report at the end. Next slide, please. So I won't go too much into depth in this slide, but I just want to sort of give an idea of some of the key things that you get when you take part in a CLEAR programme. And I think probably the biggest one, and although it's the one some people find most challenging, is that you get to analyse large amounts of data. The way that they're presented in our dashboards makes it easy to navigate through and really sort of dig down into that data and see what's going on. So it's a really nice opportunity to work with data in a nicer way than just looking at all of that raw data. But I think probably the key is the education for the staff and the skills that you're building and embedding in those services to really sort of build that passion for transformation and get people excited about change. Next slide, please. This is just quite a nice illustration of the spread of the projects we've done so far. We've got over 70 staff now working on projects all across England. And where you can see the blue there is all of the different regions that we've done projects. So over 50 projects completed so far, and there's lots more underway as we speak today. And you can just see there some of the services and areas that we've focused in on for some of the projects. So UEC, primary care, mental health, lots of others. I won't list them all, but yeah, a real sort of broad spread of projects across England. Next slide, please. So I know we've touched a little bit on this, but the real aims of the CLEAR programme is to really make sure that the clinicians are at the heart of any change within their services, and that, you know, it truly is clinically led from both sides. So you've got the clinicians working within the services as part of the project, but also the clinicians working from the CLEAR side also have clinical backgrounds. There's lots of, again, a broad range of specialties within 33N, which is really great. And just making sure that you're building new skills into those teams that they can then take forward on to run their own projects going forward, and keep that sort of transformation at the forefront of everyone's minds, because healthcare is an ever-changing entity, as we know. Just to think about, is there a new way we could do this? It's so easy to sort of get stuck in that, oh, this is the way we've always done it. So it's nice to sort of have some fresh eyes to come in and question, is there another way that we could do this? But I think probably the most important is that it's clinically owned by the teams that are running the projects and working on the project, because that's the way it sort of becomes sustainable, and it becomes more embedded within the service if it's owned by the clinicians who are working in that service day to day. Next slide, please. This little graphic just shows you if you're involved in a CLEAR programme, full 26-week programme with associates, this is the sort of the timetable or the plan, as it were. And it just takes you through nicely through the phases, clinical engagement, all the way through to report writing at the end. And I think it's important to just sort of note that at the end of each phase, the associates present the findings from each phase back to the key stakeholders, so that they're involved at every point in the project and can have their input as well. So they're kept well informed throughout the process. Next slide, please. So I'm now going to hand you over to Louise, and she's going to start off telling you about how they ran their CLEAR programme within Frimley.
Thanks, Lisa. Next slide, please. So as Lisa mentioned, my name's Louise. I work on the Frimley site as a nurse practitioner in the Frailty team. So prior to starting this project in May last year, we already knew that we had this ageing population, and we knew that it was affecting, you know, the needs of our cohort of patients that we see in the Frailty unit. We were aware that there were sort of system-wide challenges which affect the flow of our patients through the system, meaning that our patients are having long waits, particularly in A&E. We knew that bed occupancy was really high, particularly for our demographic, and many of our patients, unfortunately, are remaining in hospital despite being medically fit due to a number of different factors. And that actually 50% of older patients living with frailty have really long length of stays of more than 21 days in hospital. So this sort of formed the basis of the aims of the project. If you go to the next slide, please. So the scope and the aims of the project was essentially to look at both sites. So Frimley and Wexham are geographically quite far away from each other, and have quite different patient sort of cohorts as a result of that. But we wanted to reset and kind of reevaluate what was working and what wasn't working for both of our teams, and to allow us to become more aligned as a result of that. So we wanted to gain an understanding really thoroughly of what the current services are, and what we can do and what we can't do, to help us identify those gaps for the patients within UEC. And this we would generate recommendations, as Lisa mentions, to optimise and improve the efficiency of our team using the existing workforce that we have. And this was all, as I mentioned, as a goal to future-proof our frailty service from that increasing ageing population that we know is coming through our doors. Ultimately, we wanted to have an effect on admissions, reducing them, and also the lengthy stays for our patients. Next slide. So now I'll chat a little bit more about what we found from our project. So if you go to the next slide, this slide represents the key findings from our clinical engagement phase. So that was where we spoke to 61 different stakeholders that all had different interests in the frailty services that we run cross-site. And from the clinical engagement process, we came up with these 5 key themes that kept coming out. The first one relates to collaboration and how that wasn't perhaps being optimised. And that relates to a number of different factors. So collaboration between our frailty teams, so in Frimley and at Wexham, and that we weren't quite learning from each other and doing things the same way, which was one of our sort of trust goals, was to create unified services. We also found there are opportunities to collaborate more with different specialties within the trust, for example, the medics and also the surgical teams in the hospitals. And also something that came out really strongly was collaboration wasn't quite optimised with our community services. And this is something that fell slightly outside of the scope of this project, but it was really important that we keep coming back to it, as it suggests future work opportunities there. Secondly, we found that estates and resources could be improved upon as well. So this relates to a number of different things, but one example is that our same-day emergency care units that we had at that time were located quite far away from important places like our office and A&E, where we spend lots of our times, and we timed it once, and at both sites it takes almost 5 minutes to walk from one to the other, which obviously indicates how inefficiencies can come about. And also we heard from A&E staff that actually being co-located was really important in maintaining that visibility, and for them to feel like they were able to come to us for advice all the time. Thirdly, frailty workforce was commented on quite a lot, and particularly this related to on the Frimley side, our use of locum consultants and how that can really affect our workforce and how junior members of the team felt confident in carrying out their roles, and that there is a lack of consistency in general of our workforce itself. Fourthly, training needs came out very, very strongly. So one thing that was mentioned was that there's no frailty sort of mandatory training for all trust staff, which was felt that it would be beneficial for that to be the case. And also training within our teams, there was sort of a lack of time to prioritise this. And lastly, we looked at processes and pathways quite a lot. So this relates to our same-day emergency care beds not being ring-fenced, so we weren't able to fully utilise them. For example, when there were high bed pressures, the SDEC beds would get taken away from the frailty unit, which clogs up that system from flowing nicely. And also the fact that in different areas of the hospital, the radiology requests and actions would be slower than in others, which impacted our patients as well. Next slide, please. So once we finished clinical engagement, we then applied that to the data that Lisa explained more about. And after triangulating the data together with the clinical engagement data, we came up with a set of recommendations. So on this slide, we talk about the sort of longer term recommendations, and the next slide, we talk about quick wins. Retrospectively, some of those quick wins are more longer term recommendations, but we'll discuss them separately regardless. So firstly, we discussed reintroducing the frailty coordinator role within ED, slightly tweaking it so that we were more present physically in A&E for when the patient actually comes through the department doors, and that meant that we would be able to be more proactive, but also we would get started on our assessments of our frail patients quicker and hopefully get that system moving a bit more. We wanted to take more referrals directly from primary care and the ambulance crews to again cut out the middleman a little bit. Secondly, something that came up in the data, in the quantitative data, quite strongly was that there was a gap in the service that we were providing because of our limited working hours. So currently we work 7 o'clock in the morning till 5 p.m. at evening. But the data suggested that if we extended our services 8 till 8 p.m, we could access more patients and we could have more of an effect on admission avoidance and reduce that inpatient length of stay as a result of timely, proactive frailty assessments. There were some changes that we suggested to be made to EPIC, which is our electronic patient record system, which would mean that we spend less time in front of a computer and more time with the actual patient. As unsurprisingly, there was a lot of work that was suggested to enhance the training and development of our team, and as a result, we suggested introducing a role, training and development role itself, that was responsible for regular training in and out of the frailty teams themselves, making sure that frailty training becomes mandatory, developing a frailty champion role, which would essentially be one or two clinicians from each ward, which would be allocated to this role. We would cascade information down to them, and then they could easily cascade it down to their colleagues on their wards. And finally, we suggested a development opportunity for a community matron secondment into the frailty team so that we could link up with our community colleagues more and learn from each other in that way. Ultimately, we suggested that the same-day emergency care units and the frailty offices would be located closer to A&E, which would obviously make us more efficient and visible to our colleagues there. As I mentioned, this is definitely a long-term goal and something that we will work towards more in sort of 5 to 10 years, I would imagine. And lastly, collaborating with our community teams to make our referral and discharge processes easier, again, spending less time in front of a computer and more with the patients, so streamlining our referral forms. Next slide, please. So as I mentioned, there were quite a few quick wins that came about out of the project. Frailty training, as I mentioned on the previous slide, is not really a quick win, but something that sort of evolved as time went on during our project and quickly became more of a longer term job. Being more collaborative with our Frailty teams on the other site. And this is a quick win that we are working on at the moment, making sure our data collection is identical on both teams. Ensuring that the patient flow in SDEC is prioritised and sort of getting the word out to other specialties that this is the case, generating the Frailty champion role, which I mentioned, and the workforce surface hours, which was sort of a quick win to the mid length of time. And then ultimately, after we finished introducing these recommendations and quick wins, we suggested rebranding and relaunching the Frailty team to sort of re-advertise the fact that the Frailty unit work in this particular way. Next slide, please. I'll now hand you over to Kate, who talked to you a bit more about the finances.
Lovely. Thanks, Louise. Hi everyone, I'm Kate. I was leading alongside Louise, but as associate on the Wexham side. I'm a pharmacist by background. So the next couple of slides are just going to talk through some of the potential cost savings of those recommendations and projected sort of savings that we might see once those recommendations are implemented. So this slide is specifically for Frimley. We were looking at a data set of the emergency care data set. We unfortunately couldn't see specifically exactly the patients we did see, but we were able to pick out a cohort of patients which we were most likely to see as a Frailty service. So that was those over the age of 65 presenting to A&E by ambulance with a Frailty related presenting complaint. So that there was a whole host of them, but it was to do with altered level of consciousness, unsteady when walking. We were most likely to see those that sort of mapped those to our Frailty syndromes. So at Frimley, there were calculated to be 54,000 bed days available per year. That's calculated from our elderly care beds and those that our cohort move into. Of those beds, our cohort take up 64.2% estimated of those beds within the cohort. So that's quite a significant number of the elderly care beds. So as those recommendations, we were to aim to reduce the length of stay for those patients admitted for more than one day as a result of our recommendations. At Frimley, the median length of stay for our cohort was 10 days of those admitted for more than one day. If we were to reduce that by 20%, so 2 days, we anticipate that we could be saving 7,318 bed days per year, and that would release at 13.4% of the capacity within the hospital. And then if we times that out by costing in the cost of the attendance, the ambulance costs, the ED costs, the bed days to stay overnight for that period of time. At Frimley specifically, that could be a cost saving of potentially up to 2.1 or almost 2.2 million pounds per year. So significant amounts of money as a sort of a best case. We move on to the next slide. This is pretty much exactly the same, different numbers, and it's the Wexham side. So they have 54,000 bed days available per year, which is very similar to Frimley, but a larger proportion of their beds are taken up by this Frailty cohort of patients that the Frailty service could and should really be seeing. So 73.1% of those beds are taken up by our patients. If we were again to try and reduce that length of stay by 20%, the median length of stay for Wexham was 11 days for our cohort, so reducing it by 2.2 days, we could save 8,290 bed days per year and release 15.3% of the bed capacity. So a similar but slightly larger number for Wexham at 2.4 million pounds saving if projected, if we were to be successful with our recommendations. We move on to the next slide. This next slide, we hope demonstrates how our recommendations will impact both the patients and the trust. On the right-hand side, we were referring back to this as much as possible throughout the project as to how this fits within our trust strategic ambitions, values, and visions for the future. So ultimately, for our patients, we hope that by improving our service, and we'll be seeing more patients that have access to a comprehensive geriatric assessment by a specialist team in the right place at the right time, and ultimately hoping that that will improve satisfaction and outcome and experience for those patients, getting them sort of holistic care by a specialist team. Reducing prolonged hospital stays as well for those individuals. As I said, trying to reduce that length of stay by 20% of those admitted for more than one day. For the trust, there's a big push for the adherence to our 4-hour target. We hope by placing ourselves right at the front door, not just in the emergency department, we'll reduce that time, and our frailty assessments will be held starting as soon as possible and slightly quicker. Reducing the admission rates and bed days for our frail patients, as I've mentioned previously. We hope that our staff will feel empowered and supported within managing frail patients, so not just within the frailty team and the frailty service, but within the wider hospital, the emergency department, as well as the non-elderly care wards and elderly care wards as well. So one of our trust strategic ambitions is to make our money work. We hope those figures before, and there's some figures again later, we'll hope to demonstrate that with our recommendations may well do that, but also, as Louise previously mentioned, we want to future-proof our workforce to meet the needs and the demands of our ageing population. So if we move to the next slide, is sort of just referring back to the figures before. Our current cohort, so those over the age of 65, brought in by ambulance and with a frailty-related presenting complaint, costing out how long they stay in hospital, all of their ED attendances. So our current service or current cohort of patients are costing £15.6 million per year. So that's the cost of doing nothing. That's currently where it sits. We hope that increasing our frailty service working hours will give 2,190 extra additional service hours with no extra cost to the system, as to how we've mapped that out with the workforce data and workforce planning. This number of 16,739 is adding the Wexham number and the Frimley number of bed days that we've saved per year, and the £4.6 million of cost savings is again adding those two totals together across the trust. We hope that we'll be saving that, and the final number of £339,000 is potential cost savings by extending those service working hours and increasing admission avoidance. So hopefully these numbers are huge, and they are demonstrating that the potential impacts of and how significant this cohort of patients are to and potential burden on the system, and how we hope that we can try and reduce those costs and make savings in the future. So if we move to the next slide, was just a summary as to our project. We hope that this project's provided opportunities for implementation and to develop both local and national initiatives to improve care for frail patients. If as we've demonstrated, if we were to reduce admissions, we have potential to significant cost savings, ensuring patient good patient care and experience and better outcomes for our patients, which it seems to be only positives really. And then, but ultimately it all hangs on system-wide working. We need collaboration between our acute frailty services across both sites, but also our partners within the community, and also our sort of colleagues within the hospital as well, to all be on board to push this new model of care for its success, hopefully in the future. So thank you very much. We'll move on to the next slide, and I'll hand back to Lisa for some reflections.
Thanks, Kate. Well done, guys. That was, it was really great to see, the project in a nutshell there, and it really sort of doesn't give grace to the amount of work that you guys put into it. So I just want to sort of emphasize that it was a really big piece of work, and took a lot of hard work and dedication. So well done for that. Like Kate said, we're now moving into our reflection section, and this is just a bit of a conversation between with the associates, just to sort of find out their personal reflections and experiences of working on the programme. I can see that there are some questions already coming into the chat, and we're not ignoring those. We do have a question and answer session at the end, so we'll definitely get round to those and get those answered for you. So just from a personal reflective perspective, and having been worked on the project with you guys, I think probably one of the most impressive things for me was the amount of people that you managed to engage with. Over 60 stakeholders across all parts of the system, out into the community, ambulance teams, community matrons. It really was a feat of sheer will and dedication to the cause. So well done on that. And it did cause its challenges, which I'm sure you will shed light on as part of this reflective section. So firstly, I'd like to sort of start with what you would call your positive takeaways from working on the CLEAR programme, and what you felt really went well and really positively enjoyed as being part of the process. And we'll start with Louise.
So I think Kate will probably agree with me that the best thing about it was being able to take that step back from practice to really have the time to thoroughly go through things, understand where the gaps are, and that is just not an opportunity that you kind of get every day to do at work, because there are always differing priorities. So that was really good for both of us, I think. Personally, it really gave me a boost in confidence. I think if I'd have presented this a year ago, I would have been, much less competent and definitely less confident. But now, sort of presenting to large groups of people doesn't really bother me, and I'm quite confident in that. And I'm pleased that opportunity was there to help that. And then finally, from me, it sort of lit a bit of a fire in my belly for transformation, and it's something that I've taken forwards as I've progressed in my role in the last couple of months, and something that I think will impact my career going forwards forever now.
No, that's really nice. I think the nice thing about that was that you said it's lit a fire in your belly for transformation, and I think that is one of the best things that can come out of working on a CLEAR programme. But just touching on that first point as well, that you actually were then, because you were part of the programme, you got protected time to do that. I think that's such a huge thing in the NHS, isn't it? When you're asked to do these transformation projects, unless you're given the time to do it, it's almost impossible. So yeah, that's really nice. Thanks. And how about you, Kate?
Yeah, I would completely agree with everything Louise has just said. It's been a great opportunity to build confidence and skills in areas that I generally haven't had in the past. A lot of the training and qualifications I had have been clinical, whereas this was really sort of taking a step back from that, and gaining skills in presentation, as Louise said, but also data analysis, project management, and sort of really understanding how projects work. So I've not had the opportunity to do that in the past, and I know that sort of obviously the main outcome of these clear projects is to try and improve the service and develop recommendations that are successful and cost saving, and there's lots of positives to come out of it. But from a personal point of view, I really feel as though the clear project really sort of builds on the associates, and there's a lot of sort of training and teaching that comes alongside it to help build those skills, which are just a massive positive and a great takeaway, and is an added bonus, of course, for me personally, that hopefully these recommendations will be very much cost saving and there's lots of impacts for the future. Another sort of point that I hope that I found as a positive was sort of the networking, the ability to, when we were speaking to all these 60 odd stakeholders, really understanding what their role is within the service, and showing these people whose names I've heard of before, but I've never really spoken to. So meeting them and talking to them about their concerns, and I don't think those conversations would happen otherwise, especially definitely not between myself and them. As I say, it's sort of a different job. It's been an opportunity for me to look at things not as a pharmacist, but to sort of have my clinical hat on to give my opinion, but also to have just take a look at things from a different angle. I think has been really useful and something that I definitely will take forward into my new role. I'm already sort of looking at the service that I've just recently joined and looking at things as from a sort of a clear point of view as to how to make improvements and efficiency in workforce things. So similar to Louise, really, in that a bit of a transformation hat on now, I hope.
That's really nice to hear, actually, that you've just said that you've taken the skills that you've learned as part of this programme and now taken them on into your new role. And that is absolutely what Clear is about, is that it gives you those skills so that you're then armed and equipped to take them forward into your career. Because like you say, you didn't really know how a project worked. And I think the methodology is really nice in that it's simple enough for you to be able to break it down and apply that to any sort of transformation that you do. So that's really nice. Now, of course, with the positives comes the challenges, and there definitely were some challenges along the way. So it'd be nice to sort of hear what you found the most challenging about this process. And we'll come back to you, Louise.
Yeah, so there were lots of tiny challenges, most of which we overcame. And you mentioned clinical engagement to start with, and it was really positive. It was difficult to engage certain people, so we had to go. We changed tack, didn't we? And had to go through ED and talk to people face to face, which just worked for them better. And we just tweaked our approach a little bit. Which we overcame fine. Sometimes we got points of views that, felt like a bit of a stab in the heart, but you just take your clinical hat off and put your clear hat on, and it wasn't too much of a problem. I think time was probably something that was a limiting factor that we didn't really anticipate, because we had to deal with a lot of industrial action and of pauses, and we just had to overcome them, which we did, and we still delivered on time, and we didn't have a last minute rush, so it all seemed nicely planned in the end. The largest challenge for me, as I have now started working with the Clear team again in the next phase of the project, which is implementation, is actually applying those recommendations that we came up with in sort of the best case scenario situation and applying it to real life. And we have learnt already over the last sort of 6 weeks or so that it's not going to be possible to do all of them at the moment, at least. And so we have had to realign our expectations a little bit. And also things change. I mean, when we started this last year, we were already looking at data that was, already a little bit old. So things have changed, and our recommendations have been tweaked as a result.
Yeah, I think that's a really good point there. Obviously, it's great that we're clear are staying on. We're supporting you to implement as part of an implementation phase. But really interesting there that you said, obviously this was such a huge piece of work and so many recommendations came out of it that it's just not possible to implement them all, straight away. But like you said earlier, it's a process. There's a 5-year plan. And those recommendations will always be there for you to refer back to sort of implement them step by step. And I think just one other point that you said there about when you're going out and engaging with people, and some of the comments that you get aren't necessarily what you would expect for your service, and that can be quite a hard pill to swallow. And probably one of the hardest lessons to learn actually about change is you have to be able to take on board that feedback, because that's the only way you can make good change. So really, yeah, thanks for that reflection. And how about you, Kate?
So I'll probably just build a bit on what you were just saying there. I think the greatest challenge, but actually maybe something I've really taken away from it and a skill I've hopefully built on, was naturally there's always a bit of apprehension with change. Disrupting the norm can be daunting, especially for everybody involved, people initiating the change, the people that the change is affecting. So I think that there was a challenge there in overcoming that, finding the balance between sort of Claire's blue sky thinking and perfect situation, and then the real work of the people that have been in the service for a very long time, and trying to find that balance and mediate between the two, to try and find an outcome that's sort of backed by evidence, and sort of justifying that and taking feedback on board. I think it was trying to find that balance that I hope that we have managed to do, but sort of a bit of mediation and sort of challenging conversations at times, but hopefully we've sort of overcome those things now, and everybody is sort of on the same page and understanding that the change is good and hopefully better for everybody in the long run.
Yeah, absolutely. I think that's probably one of the most challenging things actually, is people are very fearful of change, or can be very fearful of change, especially if they feel like that affects them, if it's their working hours or the way that they work as a service that they've really got used to. And I think probably it's probably the most personal as well, because these are the people that you're working with every day. And that's why it's so important to sort of almost bring them on the journey with you every step of the way, so that they're part of that journey, and it doesn't feel like they're just being told, well, this is happening and we're doing this, that the regular feedback and sort of conversations with them happen throughout the process.
Yeah, definitely.
Yeah. No, it's really nice to hear your experiences of the programme, and that overall they were really positive. So thanks for sharing those with us. We're now just quickly going to hear from Lucy to hear her ICB perspective, and then we will move on to our question and answer session at the end.
Thanks very much, Lisa. Yeah, so I'm Lucy and I work in the Frimley ICB people team. Next slide, please. Thanks, Amisha. Yeah, so a quick bit of context about the Frimley system. So Frimley ICS serves a population of around 800,000 people. We're based in the southeast, and we serve populations in parts of Hampshire, Berkshire and Surrey. Our overall ambitions are to reduce health inequalities and to increase healthy life expectancy. Next slide, please. Thank you. And in terms of the workforce transformation space, we're led by the need to redesign workforce in line with the NHS People Plan, and then more recently, the NHS Long-Term Workforce Plan. And we're aware that there are many improvement tools available for NHS organisations, and they are used very effectively within within organisations in our system. But we embraced the CLEAR methodology and wanted to add this in as an option available to organisations. Partly very pragmatically, there was some funding available, and we were really grateful to Health Education England at the time that we were able to enter this opportunity because of funding that was available. This allowed us to test it within the system. We also were really attracted by the high level of support that's on offer to clinicians and teams wanting to enter into transformation programmes. As you've seen today, there's such an amazing offer from data analysis and the dashboards, allowing the data deep dive, which was a really nice thing. To be able to support the recommendations and the project throughout, the skills-based element, and I think we've seen really clearly how much that benefited both the individuals involved and how we anticipate that it will benefit our organisation and our system, but also future organisations that these clinicians go on to work in. And we were also keen on the 5-year planning trajectory that would be supported by the recommendations that can come out of the CLEAR projects. Next slide, please. And during the time that the project was running, we also worked with Oxford and Thames Valley Health Innovation to evaluate the rollout of the CLEAR programme for the system. And we drew out some lessons learned to inform the ICB's approach to workforce transformation for the future. And this is a published report if you're interested, and we hope that the recommendations would be transferable to other systems as well. So we felt that the ICB can support workforce transformation on an ongoing basis by providing chief people officer involvement and that senior level involvement for unblocking any issues that occur, and also driving and helping to socialise the CLEAR methodology and the programme at that level was really important to us. I think the umbrella view of the ICB and acting as and the umbrella view of the ICS means that we can develop relationships really nicely and help projects at the initial stages, but also through to the next stages and going forwards into implementation if there are other parts of the system that need to be connected to the work that's ongoing. We provided governance support, particularly in the early stages and the setup of the project. Funding either, and going forward, perhaps that might be internal funding, or it might be support for business case building for other teams and areas that want to implement the CLEAR programme. And then potentially the sharing of ideas and spreading methodologies. Lastly, we felt that it was really important for the ICB to put workforce transformation front and centre within its ICS people strategy. And we felt that the conditions that facilitated this project's success, based on the feedback that was collected during the evaluation, was having board to floor engagement, senior sponsorship, the protected time for clinicians, which we've heard was really, really important, project support available. The approach included a that was very heavily led by co-design and communication and engagement with many stakeholders, and that was really important. Clear evidence-based aims and objectives, funding, opportunity for skills development, as we've heard, and then demonstrable return on investment. Thank you. And I'll hand back to Lisa for the Q&A.
Thank you so much for that, to Lisa, Louise, Kate and Lucy for sharing your experiences and insights. Lots of rich learning and hopefully practical takeaways for people as well. So I'd like to open the floor now for questions. So please do raise your hand using the hand emoji or put your question into the chat. We do have a few questions in the chat, so I'll come to those now. So there's a few questions and comments from Tina. So we'll start with Tina's first question. So that's if health and social care systems are only identifying frailty in the acute setting, we are reacting, not acting proactively. Great to see awareness of frailty developing in the acute. However, what's happening in primary and community part of the UEC pathway? So who'd like to pick that one up? Kate or Louise?
I think it's a great point. I hope that maybe leading by example, or it's something that would be transferred out into the community if it's so heavily embedded within the hospital systems. I'm not sure what's in the in the pipeline for frailty in the community. It's not something I've been involved with. I don't know if Lisa, you've got more to add. You're on mute, Lisa.
When we were doing our engagement out in the community, we spoke to the ambulance teams and we spoke to community matrons, and there's already a lot of work going on out in the community with UCR, so preventing any of those conveyances coming in for the ones that can be managed at home. So that was implemented probably around about the time we started the project. So that is already in place, and I think having effect on patients arriving at the front door. I saw your comment as well about the ambulance teams and about them having access to an app and being able to put frailty scores on that. They weren't quite there with that yet. We spoke to one of the leads for, I think it was CCAN, wasn't it, Louise? For one of the ambulance services that feed into Frimley, and she was doing a lot of work and training with her team on frailty scores, and that sort of came into that staff training part of it. So yeah, there's definitely work happening in the community, but it was unfortunately out of scope for our project to be able to make any real change and recommendations for them, but certainly something we raised as part of the project, that that system-wide approach is definitely key.
Thank you, Lisa. There's another comment here from Leanne. I am looking into adapting my care coordinator role to include frailty and reduce hospital admissions. Wondered if we have any insights to add to that. Kate or Louise or Lisa?
Yeah, I think proactive identification of frailty and awareness of managing frailty. We know that this cohort of patients have a long stay, and once they're in, it's difficult to get them out, and there's deconditioning and delirium issues with this cohort. So anything we can do to raise the awareness of that, preventing those things. So frailty is everyone's business. It does seem as though everything's everyone's business, but it really is. There's so many patients, and that number is only getting more as people age and live longer. So we hope that just developing frailty roles within the community and within the hospital and raising awareness will slowly, gradually reduce the burden on our services, and trying to keep them at home, admission avoidance, and supporting early discharge of these cohorts to keep them at home for as long as possible.
Thank you, Kate. I'll just come to a few more questions in the chat, and then I'll come to Tina for her questions as well. So one from Rachel: does the impact data also factor readmissions?
I can take that one. So we did look at readmissions, but I think you're talking about the impact slides. So that the 20% reduction was just focusing on the initial admission, not the readmissions. The readmission data was held locally, and it was being audited at the time. And there was, particularly on the Wexham side, quite a problem with readmission of their frail cohort. So I take your point. If we're trying to get them out. We're trying to get them out quickly, but sometimes they then end up bouncing back, don't they? So yeah, I appreciate your point there, but no, those impacts were just those very initial admissions.
I think also we had some issues in that what we were looking at was the emergency care data set, so not necessarily those that we saw as a frailty service. We were just seeing those that we were most likely to see. Part of our recommendations are data collection but cross-site to really identify those patients and when they were readmitted. So hopefully going forward, as part of the recommendations and data collection, we'll be able to analyse readmission a little bit more confidently. But the only readmission data we had was national data, then we weren't able to identify those that were specifically seen by the Frailty Service, so we couldn't measure that impact, unfortunately.
Louise, did you have something to add?
Yeah, I just wanted to add that as Kate mentioned, that was part of the quick win data collection recommendations that have come about. So we are now actually recording readmission data, which is something that's going to be really helpful in the future.
Thank you, Louise. Tina, did you want to come in there as well?
My microphone working? Can you hear me?
Yes.
Because it wasn't working this morning. And I'll just type in the chat. Thanks ever so much. I just want to say well done to you guys for taking forward the Frailty banner for your organisations. But you know what, the point I wanted to make was, please don't stay in your lane when just looking at acute frailty. There is so much happening around frailty in all of our settings, and it is about bringing those, you know, understanding the whole frailty gamut of what's happening out there. You're not alone in terms of how you're trying to manage frailty and trying to keep people out of hospital and get them home sooner. You know, talk to your UCRs, talk to your ambulance teams like you have been, but also talk to your primary care networks and wider community teams about how they are proactively looking for people who may have been living with frailty and long-term conditions, because your PCN teams, people like Leanne, who are care coordinators out there in the primary care land, are actively looking at those cohorts of people, contacting them, doing assessments for frailty, and then putting in the proactive and preventative care pathways to keep them out of hospital. And what we think when we're thinking about acute frailty is, if someone gets to hospital with a frailty associated condition, it's almost like we've failed. If we've allowed that person to be conveyed, unless they're a category 1 or category 2 condition, we've failed in our mission to avoid an unnecessary admission. And that's what we want. We don't want people to have to get to an acute frailty service. But if we do want to access an acute frailty service, it's you know, it should be like same day emergency care. Let's get them seen by the appropriate people. Let's get that CGA done by a frailty acute frailty team. Let's get them home. We don't want them to be admitted, because hospital is not the best place for them. So congratulations to you guys for making that happen at Frimley. Please do talk to all of your partners around you about what they're doing to contribute to Frailty Pathway 2.
Thank you, Tina. Thank you very much. Louise, did you want to add to that?
Yeah, I just want to say thank you for your comments, and yeah, we totally understand where you're coming from. I think something that was really interesting from our data was that we were able to look at our admissions since the UCR and particularly the hospital at home teams had started, and we found that the patients that are now being admitted are much more medical, and they're really poorly. You know, the discharge rates have gone down, but that is as a result of the fact that our patients are really poorly when they're having to come in, and also their, you know, social care issues. But predominantly, these patients that are coming in are actually really unwell.
Thank you, Louise. We are sadly running out of time. I wanted to finish on this comment from Tina again, which is a lovely comment around building improvement and transformation skills. She says, building improvement transformation capability and skills from the inside is great for teams and the organisation. Making it part of BAU is going to be key to sustainability of these projects. There might not always be capacity to release time for teams to learn how to develop project management. Let's enable clinical teams to test new ways of working as part of what they do every day, which I think is sums everything up really well. So thank you all for your input, your comments. I think it's been a really interesting discussion, and fascinating to hear how the CLEAR methodology was used to design the recommendations. And I look forward to seeing how the Frailty service develops going forward. So thank you all for your time. So that's almost it from us. Please keep an eye out on our website and social media channels for details of our next webinar as part of the CLEAR Impact series. And for more information about the series and the national CLEAR team, please do visit our website at www.clearprogram.org.uk and email us any questions as well. I am conscious that we weren't able to cover every single one of the questions in the chat. So please do get in touch with us if you do have any other questions or reflections at info@clearprogram.org.uk.